Okay, perfect. So I've selected this title on purpose. I attended a conference probably a year and a half ago. This is not an original quote, but it really struck me. Change happens at the speed of trust. And by no means is this that we should be quick in our encounters with patients, but rather that we should lay a foundation of really engaging our patients in a trusting relationship as we try to move them towards the things that they need to do, continue doing well, or to do better. The other part of this is I've been realizing the more that I get entrenched in rural maternal care, creating circles of care is particularly important. When you see a patient, usually they're requiring additional services or resources that may not be in the place where you are, especially if you're in a rural community. For example, at the hospital where you deliver your patient, you don't have the capacity to provide a Nexplanon prior to discharge, or if your office does not carry that in stock for you to be able to do a Nexplanon for that patient, then that might be somewhat limiting. However, we need in those cases to work just as hard to make sure that patients can access all the options of things that they would like to consider as they're making decisions about anything from their general women's health care to their pregnancy, and then of course in the postpartum period. So I wanted to just start by saying thanks to all of you who are joining here today and those who may be listening later on. Thank you for all that you do, seen and unseen. And I put specifically billable and non-billable because a lot of the things that we do are not accounted for, but we know they happen, and that's how our patients are able to get the resources they need. So definitely want to encourage your acknowledge your contributions in that sense. In addition to that, one of the purposes of this endeavor is not only for us to be stronger health advocates, but we also want to take on the persona of a health activist. And that's the person who all of us are in terms of challenging the system that we have and making sure that it is being updated appropriately to meet the needs of our patients. Keeping in mind that depending on where our patients are, that may be a little bit different for different groups. So just very quickly wanted to give you a brief overview. We'll review a variety of obstetric and gynecologic cases, and I did that on purpose because we've talked a lot more now about preconception care as well as postpartum care, and so wanting to make sure we're including that entire scope of women's health in our discussion. Discuss some common challenges in delivering care in rural and underserved communities. Also discuss learning opportunities for how we can improve those health outcomes. And lastly, just to highlight a couple of existing partnerships. And then also to get us to start thinking big and broad and outside the box and innovatively about potential collaborative initiatives to support the circles of care. So exactly what is trust? I did a little bit of research. I think we all pretty much know what it means, but I kind of had fun with this a little bit. So it can be a noun. It's a firm belief in the reliability, the truth and ability or strength of someone or something. But it can also be a verb, and that's kind of the way that we're using it in this sense, which is to actually believe in that ability and that strength. So really another caption was to rely on another person because you feel safe with them and have confidence that they will not hurt you or violate you. So that's really what we're trying to establish in that relationship. And one of the things that I came across talked about trust as being a glue. And if you don't have that glue in place, then things just don't work very well. So for those of you who know other languages, I will not say these words, but I did include in Spanish if you wanted to look at it later. So you could, if you have a Spanish speaking patient, you could say, you can trust me in Spanish or in French or in Latin. And so just to kind of get stimulating and just thinking about, how you are adjusting your language to be able to connect with the person that you're talking to is extremely important. So I'm going to start out by interjecting a couple of different stories with patients, and I see that Claire Eden is online, and so she's going to be really pleased that my first case is related to breastfeeding. She's going to be elated about that. So I had a patient, and just so you know, these are not real names of patients. I actually Googled names of cities that are girl names, and so all the names that I've used are just names of cities, so hence Brooklyn. So she actually had a preterm delivery. and was very frustrated in her ability to produce milk. And that can happen for several reasons. Number one, if mom has a preterm delivery, and depending on the circumstances, for example, she had to have an emergency C-section, and it takes a while sometimes for the milk to actually come in, so to speak. But also there can be challenges in terms of feeding baby. And so in those cases, sometimes mom will have to pump or self-express milk in order for her to be able to provide nutrition for her baby. But this mom was actually the daughter of a friend of mine, and she called me on a Saturday morning and was really in distress because she felt like she was making milk, her breasts were full, but she could not get any milk out. And so, of course, it was the weekend, and of course, on the weekend, sometimes access to lactation support in terms of a IBCLC or a lactation educator sometimes is a little bit limited. So just trying to talk to her. So in doing her history, she was a young lady. She was probably about 21 or 22, found out that she actually had a breast reduction that had been done previously. And I don't think that, she understood or really appreciated how that would have impacted her ability to make milk. And so, of course, with a breast reduction, there's a change in the architecture. And so there's a possibility of still making milk, but the route or the pathway for that milk to be expressed is sometimes very difficult and actually not very possible. So it ends up mom can become very engorged, and it can be very painful and can be very difficult. And so this was one of those cases where I thought to myself, here's a young lady who has a preterm delivery. She's in the NICU and was very frustrated and was really feeling like a failure, already dealing with all the stressors of having delivered a baby and then not having the right support of who to turn to. So luckily her mom was able to reach out, and I reached out and was able to kind of get her some support, and really just had to redirect her that her decision to breastfeed probably was not going to happen based on the change in the architecture from her previous surgery. But I really wish that that's something that she knew up front. Maybe if she had immediate consultation with a lactation specialist earlier on, they could have prepped her a little bit more for that. They could have explored other opportunities for human milk nutrition in terms of using milk donations or milk bank. And so again, this is an example, and some of my stories are positive and some are not that great, because I want to just talk about the importance of communication and how when things don't go as planned, it's very important for us to spring into action to really make sure that we're collecting an appropriate history, doing an appropriate exam, and making sure patients are connected to the appropriate resources. And in the event, like for this mom, she was not able to provide milk, there are other opportunities for her to have access to human milk for her baby's nutrition. And so again, being able to reassure this mom, talking her off the ledge, helping her realize that she's not a terrible mom or a horrible mom, but just that there's some decisions that were made previously that are not impacting her ability to do that. So I wanted to just kind of pitch the Rotary 4-way test. So I'm actually a Rotary member, have been for a number of years. And at the end of every meeting, we repeat these questions, which I think is important because it's good to kind of always center yourself with guiding principles. And so, as you can see, ironically, the first question is it the truth? The second, is it fair to all concerned? Will it build goodwill and better friendships? And will it be beneficial to all concerned? So I think as we're thinking about how we improve maternal care for women, especially in our special populations, we have to have some guiding principles that can kind of help to center us to make sure that we're staying on course all the time. And so I wanted to share the Rotary 4-way test and encourage that we have a similar set of guiding principles. I want to talk about Asia. So this is another patient that I had, and I wanted to interject this story because it's important that when we're taking care of the patient or the mother, that we are also looking at her support system and her family. And, I have probably now almost 10 very close friends / godmothers who are now widows because they've lost their husband. And so as we're interacting in our care with our ladies, we have to, not ignore their support system, i.e. a partner or other family members. So this couple actually came to me a couple of weeks ago, and I did a pap smear on this young lady. It was her first pap smear ever. And I was very terrified to do that because I wasn't sure what I might find. She was over 50. But while, in our interactions, I was kind of checking her out and reviewing some instructions, and her husband, really sweet, was sitting beside her. And when he sat down, he had a little red spot that kind of peeked out from under his shirt. And so I said, is that a burn? How did you get a burn right there? And he said, oh, I got this thing. And I said, well, do you mind, if I look at it? And so I was being very forward, I guess, but it just kind of caught my attention. I think it just kind of winked at me. And when I kind of pulled his shirt back, he had a huge lesion that I'm pretty sure is a metastatic lesion that was eating into his skin. And so I immediately said, well, do you have an appointment to see someone? And he said, I do. He said, I got the referral, but nobody called me. And I said, okay, well, do you know who it was? And he said, well, I think it's on this street, and I think it's a lady. And so I said, okay. And so I Googled and was able to identify the practice. So I called them and I said, do you mind coming to my office? I said, can I just have a couple of minutes? Because I really felt like it was very important, based on what I saw, for him to get connected to care. Now, granted, again, this is the partner of my patient, so there's that. But I think when you see things that need immediate attention, as a practitioner, you have an ability to really jump in and help. So I called the dermatology office, and they said they had called him 3 times and he did not pick up. Well, come to find out, it was the wrong phone number. And so that's why they couldn't reach him. And so the next available appointment was in October of this year. And so I said, okay, well, let's put him on the cancellation list. And long story short, I was able to get him into a dermatology office the next year to get his biopsies done. And, he was sharing with me just how he appreciated both of them, taking the time to do that. And so I share that story because the support system is really important for that patient. And so as much as you're narrowed in on what's happening, you want to acknowledge that person that's in the room and also engage them in the care, because it really does go a long way for what happens with your actual patient. So I've come up with my own kind of guiding principles that I want to share. I'm going to just use care. I'm going to keep it really simple, connect, and I have in quotations here, by all possible ways and means, and respect everyone. And I think this is really health equity in its simplest form. If we treat our patients like the family that we love, not just family, because we may not like everyone in our family, but the family we love, then I think we have an easy way for us to really stay focused on what needs to happen. And that connect piece is probably the really important point regarding how we establish trust, because all of us are going to encounter patients who don't look like us, are not from the same place, don't share the same beliefs. So how do we go about in a clinical setting being able to quickly connect? And I think you can do that by being very aware. So for example, I watch, I'm not a huge sports fan, but I do watch the bowl games, or I watch the Georgia games, or I watch soccer, or just kind of be aware. I listen to NPR to try to see what's going on. So that way, when I have someone who comes in, I can find something to connect with. I learned how to pickle, and when I worked, when I worked and lived in Albany years ago, I had a neighbor who taught me how to make, pepper jelly and chow chow and all that good stuff. So when I have my older patients that come in, I just start talking about pickling. They would get really warm and fuzzy with me, and then I can jump into what I need to do for them. So I would encourage that you really invest some time in trying to connect with your patients. And there's always a connection point. Either it's something about the weather, or, picking okra, or I don't know, exercising, but just really making sure that we are being very intentional. And so when I go into the room with a patient, the first minute or two, where you're from, or do you have a dog, or, what did you eat for dinner, or something random. Usually if I'm asking about food, it's because I'm going to come back and talk about that later. So it's a setup question. But, I really want us to kind of use that time, that initial contact, and then use it as a lead in to what they're really needing to get help with. So Regina, I feel great. I love my baby, but I'm just irritable all the time. This is a postpartum patient that I saw, and she came to me at 6-week visit and wanted to get birth control. So I started talking to her about her mood, and I said, my usual question is, are you going to throw the baby out the window? And they should laugh at me and say, no, I would never do that. And then I'll usually say, well, do you want to hurt your partner? And they should tell me yes. That means they're being truthful. But in talking to her, she just kind of seemed like she was not telling me the whole story. And she just kept saying, you know, I feel really irritable. Like, I feel like I just, you know, want to snap at people all the time. And so I kind of jumped into, of course, did the PHQ-2 and PHQ-9 and didn't think that she was really depressed per se. But I did start by asking her, she said, well, I don't want to take any medicine. You know, I don't want to do anything. I'm fine. My baby's going to be fine. I just need to get through this period. But her kind of slight defensiveness made me kind of think about how I might change how I approach her. And so I said, you know, have you ever taken any medicine in the past? And I gave her a couple of names of things, because usually patients don't always remember. So you can kind of make a list and say, you know, what have you had? What didn't work? Or do you have any family members who didn't work, you know, do well on one of these meds? And so I said, well, you know, I really, you know, think it might be beneficial. And what happens a lot of times postpartum is moms do get a little snappy. I call it the snappy turtle syndrome. And Lexapro works really well for the snappy turtle. It just kind of calms things down, and you can kind of tolerate the crying baby and the laundry and all that good stuff. And so I said, well, I'm just going to go ahead and send the prescription in for you. I'm going to send a low dose, 5 milligrams. And it'll just be there. You can think about it. And if you think you want to try it, go ahead and do that. And then just email me and let me know if you decide to try it or not. And probably within about 10 minutes, by the time I'd gotten back to my office, she had emailed me and said, I thought about it, and I really think I want to try that medicine, and I wanted to make sure you had my correct pharmacy. And so that is an example of just the fact that sometimes when you present things to patients, they may not grab it right away, and that's okay. But again, it's about really creating that community of care where they're comfortable, they can think about it, they can make a choice, you're letting them have their autonomy, but at the same time, you're setting it up so that way, if they do decide to try the medicine, they're not making a separate call to the office just so they can get that started. So I wanted to go through a really good model that I found, and I have links for all the references for everything, but it's called the RESPECT model for effective communication. And we're going to start with the R. We're going to go through all of them. And I'll just highlight only one of them that I think is really important. And just so you know, Regina matches the R for rapport. So I'm being very coordinated here. And so consciously attempt to suspend judgment. You know, when I approached her initially about her mood, I really felt like she might think I was concerned that she might hurt her baby or something like that. And so really making sure that she was aware that I just wanted to check in with her and make sure that if she did have a change in her mood, she would have a safe space to share that with me, because I wanted to make sure that if she was well, then she would have the complete capacity to take care of her baby. So how you're framing that is extremely important. So building that rapport, and they may walk out of that room and they may act as if they have not heard you, but chances are they're going to log it, and how you've presented it to them will make a big difference. So let's talk about Eden. So Eden actually is a name based on Edinburgh, which is in Europe. So this is a case that happens very often. And usually I tell my students when I'm teaching all the time, you should not write a prescription for a patient without asking them, can they pick it up and when can they pick it up? Because if they have a UTI and it's Monday and you send the medicine in, but they don't get paid until Friday, that's a whole 5 days that could lead into something. And now they have pyelonephritis or they're heading to sepsis. And so it really would be important to ask patients about their capacity. Now, keep in mind, people are not going to always volunteer that they cannot afford $2 to pick up a medication. But if you ask the question and you have a better idea, you might end up changing your prescription to something that's at no cost at Publix or Walmart, because there are lots of meds that are on the discount list. And so again, that really needs to be a conversation that needs to happen. And there are a lot of things that patients will experience that they're embarrassed to tell you. I had a patient once who I had this whole speech on like eating properly. And then she told me that she was in a hotel because there was mold in her house and they did not have a refrigerator. So then I had to like dial back everything that I said. I said, okay, well, you can go to, Ingles and you can get a rotisserie chicken, you need a bag of salad, and you can make a salad and everybody can eat, and then you don't have to store anything. And so really you have to know where they're coming from. But the patient also has to be comfortable telling you the things that they are not sure they're going to be judged for. And so asking the right question is really important. So the empathy, and the point that I wanted to share here is seek out and understand the patient's rationale for her behaviors or her illness. Sometimes it's something that we would never think of. because our logic of what our decision making is informed by our family and our background. And there are some things that I've heard from patients, and I'm sure you have too, where you would never have imagined that that was their reason for what they were doing. And so really trying to understand. I will give you one funny story though, where that can kind of backfire. So I had a patient who's a smoker. And so I talked her into trying some medicine to help with smoking, and Wellbutrin is a common medicine that we use. And she came back and said she didn't try it because it had too many side effects. And I just like went ballistic, and I was thinking, a cigarette is like the most carcinogenic thing ever. So comparing the side effects of Wellbutrin to a cigarette does not work. But she told me her thoughts, and I discussed that with her, and she ended up trying the medicine and she quit smoking. So there's that. But you do want to know what people's hesitation might be for their choices. So Sydney, this is a funny story from very early in my career. This is a patient I saw. I remember seeing her on a Friday. She had seen 2 physicians previously that week, early pregnancy, 18 years old, blood pressure uncontrolled. And I thought, gosh, this is really scary. And so for the students that are on the phone, I was thinking about some, great pathophysiologic discovery of why she had renal disease or something. So anyhow, I admitted her and decided I would do some medicine in the hospital and watch her and try to get her blood pressures down. Well, the next morning I went to see her, and I went in the room. I sat on the side of the bed. Her best friend was in the room. And I think I'd spent about 20 minutes in the room just kind of chatting and figuring out where she was from and kind of what she was going to name the baby and was she planning a shower. And, at the end of the conversation, her best friend said, she can't swallow pills, right? And I thought, really? So basically what had happened is her medicines had been changed several times that week because her blood pressure was seemingly resistant, but she just wasn't taking her medicine, and she was embarrassed to say at the age of 18 she could not swallow pills. And so with that information, I was able to give her a clonidine patch right behind the ear, and she went home within 24 hours, and that's how we managed her blood pressure. So again, it's that communication that's really important. So involving family members, if appropriate, they are valuable. I love when my ladies bring their partners to the appointment, because they tell everything. They take joy in sharing all the things that are not being said. And even for example, my postmenopausal women who think they're fine, the partners will usually talk about their irritability or the temperature being on 65 or whatever it is. And so they can be helpful. Now, there are cases sometimes where the family members may need to be excused so you can really communicate with the patient. But it is up to you to figure out when you need some help. And sometimes the family members and friends can be very helpful. Paris. So this is a patient that I encountered recently. She was actually not my patient, but was the patient of a friend. And she had elevated blood pressures, had been to the hospital, was diagnosed with preeclampsia. But for some reason, the communication with the clinicians that were taking care of her were not really going as she expected. Her blood pressures were still high. She was symptomatic. She had headaches. And so when the friend reached out to me, we were trying to find her a doctor that was near where she lived. And so she was in a rural community. And so I was able to call another friend who's in another rural community that's close by that owns a practice. And I was like, do you know anybody that can see this patient? I need a family practitioner who is near X city. And I was able to find a physician that way that accepted her insurance and get her in the next day so that she could be seen. She got started on the appropriate medicine and really was able to turn around her care. And so sometimes it gets frustrating because there are patients, and this can happen whether or not you have Medicare, Medicaid, uninsured, or regular insurance, where sometimes you feel like your voice is not being heard. And so when that happens, who can advocate for you? And so really your healthcare team is where this comes in. And I'm talking about, if you have a therapist, they may be able to advocate for you. If you have a doula, they can advocate for you. If you have a lactation specialist, they can advocate for you. But this is the part where I tell patients that if you feel like something is wrong and you're not getting the right response, then you have to keep looking until you find someone that can really explain what's going on and make sure that you're getting the right care. And so this is kind of frustrating, especially as a clinician, when I hear things and I know what the diagnosis is, but I feel like I would do things differently. And that sometimes is hard, especially if it's not my patient, but we were able to get her connected to the right care. So partnership, this is extremely important. You want to stress with the patient and their family, if appropriate, that you'll be working together to address medical problems. And so this is key because it's not just do what I say, but why are we doing it, and let's figure it out together. And a beautiful example I have of this is a patient that I saw last week where she was diabetic, pregnant, and her sugars did not look right, not well controlled. And she said, well, I guess I got to stop eating those crackers. And I was like, yeah. And I said, well, do you have any crackers? She said, yeah, I got crackers in my purse. And I said, well, can I have them? So she gave me her peanut butter crackers, and I also took her Kind bar. I felt kind of bad, I just had them, but I think that I was happy that we had that moment where she thought about what I was saying, and she thought, you know what, I have some in my purse, I probably should not eat those, let me give them to you. And so really being able to partner with the patient is extremely important. So Egypt, I thought that would be a fun name. I could not find an E to go with my story. But this is a patient I saw recently who I did an annual exam for, a perimenopausal patient, and her hemoglobin A1C was elevated. It's like a 12. And she said, well, I don't need medicine. I'm on a really serious diet. And I thought a serious diet with some help might work, but not diet alone, not at this level. And so really she had already seen her PCP. And so I really kind of fussed at her in a very nice way. I guilt tripped her because she's a grandmother and a wife and a mother. And I just talked to her about the importance of really getting her sugars under control quickly, and was able to work with her and her PCP and the pharmacy to get her the right supplies. She ended up finding a coupon online for a continuous glucose monitor, and really just kind of setting her up. I was able to connect her to a nutritionist so that she could get more help on what she was trying to do. But the interesting thing is she had been adamant and had told the person she saw before that she would not take medicine, and she needed at least 3 to 6 months. Well, I told her in 3 to 6 months, her kidneys are probably going to be suffering. And so we did not want to wait. And so with that in mind, you know, you want to check in for understanding, because sometimes people hear things or they're going off their base of knowledge. And lately I have been detoxing from TikTok a lot. And so really you have to know what they are using for their understanding. And you have to check in over and over again to make sure that that is correct information and that you're updating appropriately. And so again, just explaining and being very specific. So when I talked to her, I talked about the effect of diabetes on the eyes, on the heart, on the nerves, on the stomach. I mean, I get very specific. And so she kind of was like, okay. And so I think that was helpful to kind of engage her. And she actually did end up accepting medicine from her PCP after that conversation. So the goal here too is when you think about the circle of care, just because as a OBGYN, the patient may sometimes, if they have chronic morbid conditions, have their own PCP, but it's not enough for me to just say, oh, the PCP is going to handle that. Once they're under my care, I am also responsible for encouraging the appropriate behaviors, supporting what the PCP has encouraged them to do, and be very helpful. So don't draw boundaries on your level of interaction with patients, because they're still your patient as well. So Charlotte, this is a patient, this is one of those not so good stories. She delivered, young patient, elevated blood pressures in the hospital. We were able to control them with medicine. We were able to enroll her in a program that we have at our hospital for postpartum, where we can actually, we have remote blood pressure monitoring. And so they take it twice a day for the first week, and then we get the pressures, and then we can adjust meds and you know, really watch them. And if there's a problem where it's escalating, then we can bring them into the hospital and do the appropriate care. So she promised me that she was going to take her medicines, and she promised me she would take her blood pressure, and she promised me she would not eat any ramen noodles. And then we couldn't find her. We texted her, we called her, she wouldn't answer. And we were getting the elevated blood pressures at one point. And she kept saying, well, I'm going to take my baby to the pediatrician, and then I'll come see you afterwards, you know, while we're looking at these blood pressures being elevated. And when she finally came in, she had to get readmitted. She definitely had preeclampsia, but even worse than that, she had congestive heart failure. She had an ejection fraction of like 40%. This is like a patient under the age of 25 who was semi-fine, I guess, when she left the hospital, and then just deteriorated. And part of that was, we're trying to reach out to her, trying to engage her, and she just was just resistant. And so felt kind of like a failure. And I thought about it a lot. What could we have done differently to engage her? And that's probably where, we did talk to her partner and her mom, but I don't know that they really heard what we were saying about how serious it was. And so, she ended up having to be admitted. Like I said, she was in the ICU. She was able to go home. She saw the cardiologist afterwards. But it's hard sometimes when you do everything you can to reach out, and then it doesn't really work the way you want to. And so I thought the next time, if I were to be in that position, who else could I recruit from the community that she respected, that could be helpful? And maybe if I talk to her pediatrician, if she's going to her pediatrician more and not coming to the OB visit or the postpartum, would the pediatrician be able to help? And so sometimes those frustrations help you think broad about how you can engage your patients. So with that, the cultural competence, understanding how personal style can impact when you're working with a patient. And maybe she felt like she couldn't connect with me, or I didn't understand her. And so again, just being very mindful of, you always learn something when things work or they don't work. It's always a learning opportunity. So here's Tracy. This is a really interesting story. This is a patient who saw for birth control, and I was mad at her because she was not taking her pill. And I was like, you're being non-compliant. I hate that word. No, I don't ever use it. I use semi-compliant, not non-compliant. And so she said to me very candidly, probably about 17, she said, can I be honest with you about why I don't take my birth control pills? And I was like, sure, tell me. She said, my boyfriend really wants me to get pregnant. So every time I take my pills home, he hides them. So I can't take them. And I stopped and I thought, okay, that's like a legitimate issue, right, with her compliance. And so I was fussing at her because I thought she wasn't taking her pills, but there was another force that was interrupting or interfering with her ability to be compliant. So basically together we came up with a new place, and she hid them under the mat, passenger front seat. And so that's where her pills were. She could take them when she went out to the car, he wouldn't know, and she could take her pills fine. So it's important to really take an opportunity to really connect with your patients and figure out what's going on. Take the time necessary to consciously work to establish trust. And that's why this trust concept is so simple, but so critical, because if the patients don't trust that you have their best interests at heart, or that you will not judge them, then they're not going to tell you the stuff that sounds absolutely absurd to you, which you need to know so you can help them problem solve through those things. Savannah. So this is a patient I had recently, and she really was so sweet. So when I met her, she was smoking 2 packs of cigarettes a day. She came to me as a referral from the health department, had a pretty impressive, what we found out to be a basal carcinoma lesion. No insurance. I was able to do her general care pap smear, get a mammogram, get her colon cancer screening, and got her in for a biopsy. Because she did not have any money, we had to do some collections to help support that process. And I was actually able to reach out to my Rotary Club, and an anonymous donor wrote a check for the entire cost of her procedure, which was significantly discounted by the dermatologist who's going to do her procedure actually on the 26th of this week. So I think that's Wednesday. But I've been talking to her about really taking care of herself. And I said, well, what are you down to? The last time I saw her, she said, well, I'm down to half a pack from 2, which is huge. So when your patients make progress, you have to really celebrate that progress. And she said, I'm going to really work hard to quit, because you're really going above and beyond to help me. And if you didn't help me, I don't know who would. And so sometimes really when you extend that interest, patients are able to really climb that mountain that they might otherwise have climbed. And so it's really important to, again, for them to trust you. So let's talk about some common challenges as we're wrapping up. I want to leave some time for questions. They can become change agents. When you think about transportation or resources or finances, and even telecommunication, it's not uncommon, for you to have a phone number for a patient and you reach them, you call them and they can't talk. And so being able to figure out how to work around that. So a lot of times what I'll do is I'll ask patients where they work, and they think I'm just being friendly. It is really so I can just call them at work. So if you work at Subway, I'll just call them. I'm like, what's your shift? And I just kind of log that in a note. And then if I can't get them on their phone for whatever reason, then I can find them. I have been known to show up to people's place of employment. Usually it only has to happen one time and they don't miss any appointments after that. So do that at your own risk, of course, if it's safe. But the other thing is sometimes patients have a phone, they run out of minutes, so they can't accept calls, but they can text. So using something like Doximity, which is a free app that clinicians can use where you can reach out to your patient, you can actually even text them, you can video call, and you can even tell if they've read the text message. And so really just exploring those different opportunities. The social support is really tricky. Not everyone is blessed to have supportive family. And sometimes I feel like, especially with pregnancy, like for the delivery, like everyone shows up, like the gardener, the electrician, like everyone is out there. And then once the baby comes, this poof, and everyone just kind of goes away. And so really looking at that social support is really important. Checking on finances, looking at what is available. I've had patients who have delivered and they don't have food and for whatever reason have not set up their WIC. So you can tap into local churches or food banks that have food distribution, and then you can do that. We'll talk a little bit about farmers markets now because you can use usually EBT cards there. And so really the goal here is you've got to know what's in your community. You've got to have enough friends who know what's going on. So if you run into a roadblock, you can say, okay, let me figure this out. Transportation is always a big issue. I have gone to different offices just so I could see patients because it was closer for them. So really just being very aware of what the barriers might be so that you can really kind of troubleshoot that. Transportation of patients, for example, have Medicaid. Sometimes they have to have a 3-day notice before the van will transport them. And so, but if you as a clinician call, you can sometimes even override that. So being able to know kind of what your options are for how you can support the patient. Learning opportunities, you want to leverage your senses to help you identify them. So you've got to look at your patient. I left out the smell part, but sometimes that's important too, because that can give you a clue to kind of what's going on. You're looking at how they dress. You look at, whether or not their feet are dirty. There are a lot of things that you can pick up from just looking at the patient. And I find it's very helpful to apologize. So like if I'm really opening up boxes and really pushing buttons, and I've been known to make patients cry when I start asking about sensitive things, I'll say, I'm really sorry, especially being an OB. You go from, hey, how are you, to let me look at your stuff, like your stuff that nobody else looks at. And so just being able to recognize the privilege that you have of getting very close to patients very quickly. And so I'll say, I'm really sorry that I'm, bringing up all these things, but I really want to understand better so I can help you. And so don't be afraid to do what you have to do, but also apologize if you're, having to really get deep and have them talk about things that they may not thought they were going to talk about. And of course, empathizing, just really being able to connect. Sometimes patients have difficulty with making decisions and what to do. And I'll say, well, if you were my little sister, then this is what I would say. And sometimes when they can receive it, when they think that you're thinking about them, someone that they would be cared about. And so that's also important. Existing partnerships. So I love this slide, probably the best. Find your bridges and use them. They're everywhere. One of the things that I find is in terms of our circles of care is we have a lot of resources where they're not being utilized because everybody does not know what else is going on. And so hopefully one of the things that'll happen with this webinar series that we're doing is we'll start to collect information so that way we know exactly what's going on. I learn about new programs all the time, and I wish there was like one clearinghouse where that would be housed. Health departments are a great friend in the community because they see a lot of patients for lots of different things. And so I have in all the counties where I have patients who come to visit me, I have the cell number of the nurse practitioner. They know that they can call me if they have a problem or if they need to expedite something. Our community health centers, I'm with Community Healthcare Center, Community Healthcare Systems, which is an FQHC network. We see a lot of patients who do not have health insurance, also who have whatever insurance. And so we're pretty open to be able to offer care to most people. But there are a lot of services that can be accessed by patients. And that's an especially important point right now, because with a lot of patients where their Medicaid eligibility may not have been renewed for whatever reason, they might be just floating in the wind. And so it's important for people to know that, FQHCs and CHCs are available and are partners in the community. For example, my office, we have a 403B pharmacy that offers discount medicine. So I have a lot of patients who have switched, who told me they couldn't afford their medicines before. But through our, 403B pharmacy, they can get a 90-day supply for way less than they were paying for 1 month. So again, you have to know what's available in your community so you can encourage that. First Steps covers families that are under age 5. That's a huge support for young moms who are needing services in the community. They do an assessment and they kind of can connect resources. So again, we don't have to reinvent the wheel for a lot of these things, right? We just have to know what's there. Georgia Family Connections, and of course our UG extension, they're in every single county. There are lots of services that they can provide in terms of outreach. And so it's good to know what services they can provide so that when you have a patient who needs that particular service, you can connect them to that as well. Potential collaborative initiatives, and this is the part where you really have to think outside the box. And how do you strengthen that circle of care? I think it's really important to engage the lived experience volunteers, people who have had preeclampsia, who have had a near miss, or who've had issues before, to get their perspective of what things worked well for them, but also more important, what things did not go well. So that we're filling in the gaps in that circle by using the actual lived experience. There are a lot of research opportunities that are going on where patients can access services. And that kind of ties into your connection with your educational institutions. So it's important. I really value my affiliation, for example, with Mercer, and I'm also adjunct faculty with several other medical schools, because those affiliations are very helpful for how I'm able to teach different students. Farmers markets is probably an underutilized service. That's something that really needs to be looked at. What's available in your community? Is there a bus stop that's in front of that spot so you can tell patients they can go? Are there tokens that can be made available to help patients go on Wednesday? Is there farmers market, for example, here in Macon? The farmers market that they have on Wednesdays is right across from the elementary school. So literally when they come to pick their kids up, they could walk across the street and get their fresh veggies, and then they can kind of incorporate that into their lifestyle versus making a whole separate trip. So again, I think medicine is really only 30% practice and then 70% other, and this is the other. And the last, but definitely not least, is the healthcare expertise extension. And that includes our midwives, our doulas, our nurse practitioner, a lactation specialist, like all the other therapists. There's so much support. Even for example, there are pelvic floor therapists that are very great for women after they've had babies and things are just not right. Also being able to preserve, and strengthen muscles in that area to prevent development of things like incontinence later on or prolapse. I mean, that should be part of what you have on your menu, so to speak, right? You should know at least one pelvic floor therapist that you can refer a patient to should that become appropriate. So again, we really have to make sure that that circle of care really has all the different pieces. Not everybody will require all these things, but should they, it's almost like we're building this like awesome menu that has everything on it that people can select from. So respectful care, I wanted to be respectful of time. I'll go quickly. There's a really good toolkit that's here that I would recommend that everyone take a look at. Respectful care is just really an approach where we just really look at how we're providing care to our special populations. And there's lots of good resources about how we work on adjusting our attitudes and our behaviors. And as I mentioned before, the mnemonic care, which is care and connect with everyone, really easy to do. Talking about how you start the conversation. I talked about just connecting with the patient first, being able to redirect the conversation to make sure you can address what they came in for, and then how you end the conversation. What's the next step? And sometimes, people come in and they have 10 problems. So you pick the 2 most important things and you work on those and you kind of follow up later. But I love this quote, you may have to fight a battle more than once to win it. Because there's several patients I have where it takes me 2 to 3 visits for me to really make that connection, but don't give up. Part of the issue sometimes is they're coming to you with previous bad experiences. And so the attitude they display is really like a protective shield. And so you have to know it's not directed to you personally, and you got to figure out how to kind of connect with them to get behind that shield so they can put it to the side so you can take care of them. Very briefly, we talked a little bit about mood disorders, but I really wanted to put a plug here for grief, which is really important. Since the pandemic, post-pandemic, So many people have lost very close family members, and it's really important to ask about that, because a broken heart does not take their medicine on time. Broken heart does not take care of themselves like they should. A broken heart does not take care of their family like they should. And so we really have to be able to address that. I have a quick quote here about the importance of restoring trust in the US healthcare system. And I'm just going to end with this last statement that says, mistrust can undermine the physician-patient interactions, leading to deteriorating patient outcomes and increased physician burnout. So that's not rocket science, but here it is in print. So trust, it's given freely sometimes. Think about getting on a plane, right? You don't like look up the bio of the pilot who's flying the plane. You get on the plane, you strap yourself in, and you pray that you get there safely. Babies also give us their trust very freely. You drop them off at daycare. They do not ever wonder if you're coming to pick them up. They expect to see you. When they show up, when you show up, they smile and they gurgle and they look at you. It can be earned with encouragement, thinking about relationships. It can be badly broken. For example, if someone lies about you or steals from you. But the point I want to put here is it can be repaired with effort. And I put parenting on purpose. I have 2 kids, 18 and 14. So everyone that has kids understands, or nieces or nephews, or just family, that sometimes trust is broken, but it can definitely be repaired. And in medicine, we actually have to spend a lot of time repairing trust. So I put these quotes on here because I think they're hilarious, because when you think of trust, the ones on the end can evoke fear, but the one in the middle should evoke faith. And so when we use the word trust, it depends on what perspective you're using. It can be helpful or harmful. So hopefully we're not scaring people away by the almost, and we're focused on the faith part a little bit more. So this is a pledge that I wrote for us to just leave with. I will do my best to build circles of care, which will ensure that the care of my patients will not be defined by their zip code. So if there's a service that your patients need and you're in the middle of nowhere, then it behooves us to really be able to make those connections so that we can expand that circle to be able to access their care that's needed. And these are the resources. And then I think this is it. I'm all done. I think I have a few minutes left. Apologies, I went over just a little bit, but I wanted to turn it over back to Ms. Boulay so that we can just see if there's any feedback, comments, or questions from the audience. And thank you so much for letting me share with you today.
Yes, thank you so much, Dr. Callins. I wanted to tell people if they have a question, they can feel free to unmute themselves and ask the question. And there are also some questions in the chat, so I will read those. So to you, Dr. Callins, one says, from your experience, what are the major determinants of the high maternal mortality among minority populations compared with the general population?
So I think we could probably talk about a lot of reasons, but the first thing I think about is sometimes late entry to care. I think that's a big portion of that. And that can happen for several reasons. Number one, I have patients who they've had other babies and so they don't think they need to show up until later because they've done it before. And then there are new patients who genuinely might just be terrified because of a lot of what is going on in the media. I think there's a lot of fear. And so I think people do avoid coming to the doctor. The other part is just education and being scared about what's going on. And so, or just knowing when to come in. So if you are cramping, for example, and you are, 32 weeks, do you, how long do you wait before you go to the doctor? I usually tell patients, if you are uncomfortable, you don't feel the baby move, don't call, come, let us assess you, let's send you home. So I think that communication needs to happen. But in some of the rural communities where I practice as well, patients don't live close. And so they may have something, may have transportation. I cannot tell you how many people will ride the ambulance to come in because they don't have a personal car. And when it's time for them to go home, we have to find an Uber for them to do that. And so again, that transportation component is also there. So I think it's multifactorial. The last thing I'll talk about is just access to providers. So I work in Twiggs County. I am the only physician in Twiggs County. And so that's not cool. There are a lot of counties that don't have an OBGYN or even a women's health practitioner. So if you think about access, that's another part. And so as we try to solve this issue, we've got to address the workforce, but we also have to make it comfortable for physicians to practice. Georgia has one of the highest malpractice rates in terms of, obstetrics. And so if we want people to kind of go out there and take care of patients, we also have to protect the clinicians who are going to do that as well. So I could keep naming reasons, but I know we have other questions.
So the other question is about time. They said developing trust sounds like it can't be rushed. Any tips on how to deal with time constraints that are often inherent in the healthcare systems that most providers practice in?
Yeah, that's a challenge. And I will admit that probably in a FQHC setting or community healthcare center setting, there may be some more flexibility on time, as opposed to being in a practice where you may be seeing 40 patients a day. So it is hard. But it's a good question, because I just read an article this morning that talked about, we really have to change that paradigm to allow for time for patients that need more, because not all your patients will need more time, some will. The other part of that is engaging your clinical staff to help you triage and identify the people that may need the extra services, and then having access. So for example, in my FQHC setting, we have a therapist that's here. So if I identify a patient that has depression, I can talk to them. I can do the PHQ-2, the 9, the G87, the MDQ, and then I can kind of talk to them about medicine, and I can get them to see a therapist pretty quickly. Not everybody has that accessibility. And so I have a nutritionist on staff. The only thing that I don't really have is a dentist. We have a podiatrist. And so really being able to expedite that care is really important. And so it is challenging. But I think with intention, you can get better. Now, what I typically do is I try to write down at least 1 or 2 points. I say, do you have a dog? What's the dog's name? I'll write that in my little sticky notes. I have ECW. And so really when they come back, you can say, hey, how is, Jimmy the dog? And then keep going. So it doesn't have to all happen at one time, but it needs to be at least one intentional effort to make that connection point, and then you can build on it, because it really is not going to happen. You think about the relationships that are meaningful to you. You don't become friends, best friends overnight. That takes a while to develop that. So the physician or clinician-patient relationship also is going to take some time. And I will admit that sometimes I end up talking more and not doing my charts. And so I end up doing my charts after work. I try to take work home with me, but I do know that I run the risk of kind of tipping over a little bit. And so I can't tell you that I've mastered that. I have not learned how to care faster, but I do want to give quality care. And so I just kind of, manage it as I go and try to just do it, figure out who needs more of me and give them more, and then kind of balance it that way. It is hard though.
So Dr. Callins, several people are interested in getting a PowerPoint, a copy of your slides. Would that be okay?
Absolutely. I will make one edit and then I'll send it to you. I just noticed one thing I want to add, but I am more than happy to share it. And really, it's just to stimulate the thoughts and the conversation. And everyone's community is so different. And as you can see, the stories that I've shared are very diverse, from lactation to breastfeeding to women's health to even men's health. And so really it's just really helping us to think about how we make those circles of care work to protect our patients, and no one should fall through the cracks.
Well, thank you so much. I think we might have time for one more quick question if someone has a question. Oh, Dr. Franklin.
Hi. I am so excited to engage the marvelous Dr. Keisha Callins. And Dr. Callins, several people on the call may be clinical and translational researchers as opposed to clinicians. And so I want your thoughts on how you translate these concepts of trust and the respect model into clinical and translational research, especially when it comes to the complexities of recruiting pregnant and postpartum patients into studies, and in studying the whole spectrum of maternal health equity, especially in rural communities. How do we use those concepts?
Okay, well, thank you. And everyone should know Dr. Franklin was my attending. And so I am so proud that she thinks so highly of me, because she helped train me, which is great. So I think the first thing I would say, and I will come from the background, when I finished my public health degree, I worked as a research recruiter for 2 years. And so I did research recruiting, particularly for underserved populations. And one of the things that I found is, even though people have these thoughts in their head, or historical trauma of things, for example, like Tuskegee or other incidents that have happened, When you approach patients with the concept that the information that we are going to gain from their participation will help their generation or future generations, it tends to help to change their mindset. And so I think how that approach is done, and really making sure, Dr. Franklin, that our communication, whether it be the consent form or the follow-up or how we interact with patients, really needs to be very sensitive. And it's helpful probably if that team includes people who we're trying to recruit, if that makes sense. So it's marrying the actual research team with someone from the community who can help to share that information as well. And I think that is a game changer. But there's so many myths about research and what might happen, or you're not being told everything. I'm really helping people understand that there have been a lot of advancements and protections that have been put in place to help protect the people who do participate, but also helping people understand the information that we gain is very helpful. There are a lot of things that we know now that we do differently because of research that has been done. But I think it needs to really happen at that community level. And so engaging, for example, our, I think hairdressers are one of the most influential people in the community because they talk to women all the time, for example. You know, our churches, and, you know, any opportunity that we have to really meet people where they are is a great place to start versus having them just come to us. So almost like a mobile research effort where we're going out and we're engaging, but also not just so we can get information for that one thing. It really is developing a relationship where we're going to be coming back to you. Right now, we're working on preeclampsia, but next year we're going to be working on obesity. And so we want you to be a critical part. We want your voice to be heard. And so how that information is shared, I think, is extremely important for how we engage the community in our research efforts. So hopefully that helps.
Well, thank you so much, Dr. Callins. I wanted to let everyone know that our next seminar will be on September 11th at the same time at noon, and we will be talking to Dr. Ali Berg and some of her colleagues from UGA Extension, which Dr. Callins mentioned in her presentation. So I think it's a nice fit. But thanks everyone for attending. And like I said, we'll share the slides and we'll make the recording available on the CTSA website.
Thank you. Thanks, everyone.
Thank you. Have a good day.